Hello, everyone. Good morning or good afternoon, depending on where you are. Welcome to the webinar today on AI for the healthcare industry. Looks like we have some attendees funneling in still, so we'll wait another second or two before we get started with the presentation. But in the meantime, I want to let everyone know that we are recording this session and we will be emailing out the recording and a copy of the slides to everyone to share with your colleagues or rewatch again for yourself. We also will be taking questions during and at the end of the webinar today. So if you have any questions, please submit them in the comments or in the Q&A section, and we'll be sure to get to them at some point. And looks like we're ready to get started here. So let's introduce our speaker for today, Dr. Tim Oates. Tim is the co-founder and chief data scientist at Synaptic, with over 20 years of experience in guiding organizations and companies of all sizes, applying AI and machine learning to business problems across industry. Dr. Oates earned his PhD in computer science from the University of Massachusetts Amherst with a focus in AI and machine learning and was a postdoctoral fellow at the MIT AI Lab. Thank you, Tim, for speaking with us today. I am going to go ahead and let you take it from here.
Okay, thank you. All right, yeah, I appreciate everybody coming to listen to me talk about this. I just wanted to start out to say a few words about Synaptic, the company. So the way I characterize what we do is generally I say we're a data science company, but that's a catch-all term that essentially means we do artificial intelligence, machine learning, data science, data engineering, consulting. But a while ago, we realized that often when we get involved in helping companies implement those technologies, they want to surface them to either internal clients, so they're trying to build efficiencies in their organization, or external customers. And so there's often a user experience, a product design component of that. And so the sort of better way to describe it is that we do work on intelligent products. So we tend to sort of touch all ends of that, from understanding strategy around AI to implementing the technologies to helping deploy those and get them stood up at scale. So that's all I want to say about the company, just so people have a little bit better idea of what it is that we do. So today I'm going to talk about AI applied to healthcare. And I've got case studies. So it turns out that at Synaptic, we've actually done a fair amount of work in the healthcare industry. So sometimes when I do these webinars, I'm kind of talking about the art of the possible and sort of notionally things that you could do. The case studies here are actually things that we've done and delivered to clients. Interestingly enough, as I was going through this, it's a mix of very different kinds of things. So there's what I would call kind of old school AI. And these days, when I say old school AI, I mean everything before large language models, right? So we'll see a mixture of kind of statistics, machine vision, some sort of simpler models among these case studies. But then obviously, at the end, you want to say, well, what about things like ChatGPT? So I've got a couple of slides at the end on ChatGPT, which I think hopefully will be kind of interesting. Turns out that the applications of large language models and of AI in general are very broad in healthcare. And so that would be a great time. I'm happy to take questions at any point, but especially in that sort of bit at the end, if anyone wanted to dig into, sort of what's the role that large language models can play in the healthcare industry, that would be a great place to get into a discussion. And I think I might have lied. I don't think I have concluding thoughts, but I'll try and come up with some by the time we get to the end. I don't think I have a slide on that. So we'll see. Actually, sorry, let me go back. So the case studies are improving patient intake, automating ultrasound annotation, visual anonymization for model training to protect PII, and then machine learning to reduce costs of tests. And we'll see actually sort of two flavors of that a little bit later. So the first one is improving patient intake. And so I don't know about you, but when I go to a doctor these days, they hand me a tablet that looks a lot like that. Like I think my doctors might use exactly that company because they look just like that. And so Turns out that when you dig into it and think about it, the patient intake process is super important. So, in an ideal world, you're gathering information that's going to be important for optimizing the care that you get. It turns out that from the sort of business side of things, you'd like to reduce bad debt. So you want to kind of collect those payments up front. And I bet that that thing along the top of that tablet is a card reader, and you can just swipe your card there. And then obviously efficiency is going to lead to shorter wait times and then potentially higher profit. So patient intake should be good for everybody if it works well. But people hate it. I don't know, again, when somebody hands me one of those things, I just roll my eyes and I just try and power through it as fast as I can. Why is that? Well, one reason is it's repetitive. I feel like I answer the same questions all the time. The answers never change. And it would be awesome if they would just remember the stuff that's probably not going to change. It's also incredibly impersonal. So, and by that I mean it's sort of not tailored to me. Like I'm answering the same questions that the person next to me is answering, and then it's just time consuming. And so it's funny, I was looking at these websites. Here's a picture on one of those websites, and like, look how happy that person is to be getting that tablet to fill out that information. I have never had that feeling before, right? It's just an annoyance, and I want to try and get through it. So we worked on a problem quite a long time ago, which was quite fun. It's still one of my favorite projects I worked on simply because of the outcome that we got. And it's this intake problem on steroids. So we've done a fair amount of work with doctors and other people that are in the functional medicine space. And everything I know about functional medicine, I learned from them. And I'm no expert, but the way I think about it is that in traditional medicine, if like I had pain in my knee recently, and I go to a doctor that specializes in knees, for example. If I had heart issues, I would go to a cardiologist. If I had other kinds of issues, I would go to a neurologist. And so standard medicine is very specialized, which is fine because when you go talk to those doctors, they really know the thing that they're specializing in. Functional medicine doctors take a broader view. So they're looking at you as an entire person, sort of what are all the health issues that you might have collectively, and then what are the root causes that you might be able to treat. So again, I think of functional medicine as being a much more sort of holistic approach. I'm going to look at you as a person, everything that you've got going on, and try and address it as a whole, as opposed to saying, I'm going to work on your knee pain and you're going to go somewhere else to, think about the headaches that you're having, for example. So now, great idea. The problem that arises in functional medicine is because they're not focused on a particular narrow area, they sit you down and give you an intake questionnaire that literally has hundreds of questions in it. So the order is static. It's like, okay, just answer these questions. There are lots of sections. So they'll ask about your sleep, they'll ask about your mental state, lots of other kinds of things, and there are lots of questions per section. Some of them are irrelevant, right? So if I'm a man asking me about pregnancy, it's like, okay, I'm going to skip those questions. And it does turn out that response rates can be low because we're people and we get bored. And especially near the end of the form, you're just like, okay, come on, I've been doing this for literally 2 hours. I just want to get through this thing. So what we did was we worked with a company that was in the functional medicine space that had lots of examples of these surveys that had been filled out. And what we did was we built an intelligent questionnaire, but we were using relatively simple methods. So I would say it was statistics. And, so is that AI? Is it machine learning? I would say that counting is at the heart of everything that we do in AI and machine learning, right? So what we did was we said, okay, we've got all this historical data. It's kind of incomplete because people get tired and they give wrong answers sometimes, or it's a little bit of a mess. Again, just because of the nature of people filling out long surveys or questionnaires. And so what we did was we did statistics. And so we looked at every pair of questions and we looked for when there was a positive response. And by positive response, what I mean is, like the classic example that we always sort of looked at was you would say, do you have anxiety? Yes or no? So yes. Do you have high blood pressure? Yes or no? So it's a question. A positive response is one where you say, yes, I've had that symptom. I've had that condition, right? And so what we were looking for is correlations between positive answers. And so, as you might guess, if someone says, I have anxiety, they're very likely to also say they have depression. If they have either of those, they're likely to say that they have sleep issues and a variety of other kinds of things. So, what we did then was we used those correlations to create dynamic orderings of the questions. And the idea was that you want to ask the questions up front that are going to be most relevant to the patient. So if you assume that the patient has sort of a fixed attentional span and they're really going to sort of, work hard on some number of questions, I'd like to ask the questions up front where you're going to go, yeah, I actually had that. Yeah, that's relevant to me. And leave for the end the questions that are going to be much less likely for you to go, yeah, that's an issue for me. So the result was that we actually sort of used the data, computed the statistics behind the scenes. That fed into an app that was developed. And the way the questionnaire played out was in working with the domain experts at the company, they said, like, here's the key stuff to ask. Like, you need your gender and age and things like that. But then a few other kind of key questions to get the process started. And so now, once I know something about you, I can start choosing the next questions based on the ones that I think you're actually going to respond positively to. So if you're you indicate that you're a man, not I'm not going to ask you questions about your pregnancy, right? They're going to be sort of in there somewhere, but they're going to be ranked incredibly low because, in general, unless they're making a mistake, man's not going to say, yeah, I had a past pregnancy. So the idea was I would just start surfacing questions where you're going to go, oh yeah, that applies to me. That applies to me. And then, there was some careful kind of engineering or user experience that went in there to sort of avoid what I would call whiplash by staying within a section. So, if I'm asking you about your dietary practices, and then I start asking you about mental health, and then I start asking you about blood pressure, and I'm just sort of jumping from topic to topic, that gets to be, you sort of start losing your orientation. So you sort of, here I'm in this section. Let me ask you a few questions. Okay, it looks like I've covered that. Let me move on to the next section. And it was just super gratifying because the company ran some tests with patients, and these are quotes from my memory, so they're very close to things. But people would say, like, it felt like I was talking to a doctor, right? Because a doctor, as they're asking you about what's going on with you, they don't suddenly jump. If I've got knee pain, the doctor doesn't go, oh well, how is your thumb feeling, right? And so it was very focused. It seemed like it followed a logical progression, and people said it seemed like the app understood them. And so what happened was, then you're able to gather much better data, again, given this sort of limited attentional budget that people have. So you get better data collection given those constraints. And again, like, do I call I would definitely say that this is an application of sort of machine learning in this context. And people can argue about it's not new school, but incredibly powerful end result. All right, so that's one case study. I'll move on to one that's rather different, and this one is automating ultrasound annotation. So here's the use case. And again, I learned about cardiovascular health by talking to people at this particular client. And so what they were doing was they had a system for looking at your carotid artery using an ultrasound, right? So you're running an ultrasound up and down your neck. Turns out that your carotid artery, as it sort of comes up into your neck, is one tube, and then it bifurcates, and then sort of these two sides of it move off to different regions of up in your skull. So your carotid artery, very important for your overall health. It turns out that there is on the sort of boundaries of the carotid artery, if you can see my cursor, there's a thing called the intima, and there is the media, and then the advendentia. And this intima media thickness, or sort of how thick this area is a remarkably effective indicator of your cardiovascular health. We'll talk about that in just a second. So what you can see is that a skilled ultrasound technician can actually go in and make measurements and go, there is your intima media thickness. How thick is that area? You can also look for plaques that are in the carotid artery. And so the idea is that here, for example, you've got healthy intima media. It's starting to get thicker here. And then you've got plaques, and they occur, and again, I'm no doctor, but the idea is that your body is sending white blood cells to protect the arteries, like in areas where there's sort of, bad things going on. Those things turn into fatty deposits. They make the artery thicken. When your arteries thicken, they don't flex like they should. You get less efficient blood flow. So this company had really, really good measurements of the intimate media thickness. And they did that by having very skilled technicians, and they would do multiple measurements, right? Because it's hard. Like, I don't know, I've looked at ultrasound images before. I can't make heads or tails of them. So they would do multiple measurements, and they had pretty sophisticated ways of averaging them out to make sure that they were as accurate as they could be. But it was tedious and, again, sort of error prone. So you had to have multiple techs doing the measurement. So what we did was a few things. One was sort of towards the end of the project, we built a neural network for doing segmentation. And so what you're seeing here is a video of this is the artery, and you're sort of moving up and down the neck, and you can see, okay, it's bifurcated right there. And I think at some point they're going to kind of come back down in this video. And so what we're doing was trying to build methods that could automatically identify in all of this, like, here's the artery. And in a second, you'll see another little sort of circle, right? So like now it's trying to bifurcate. And then, okay, we got a little bit of a glimpse of what's going on the other side. So what I would say is, like, very hard problem. Reading ultrasound videos requires extensive training. I look at this and I don't know, like, you look at that, like, is that the carotid? Is that the carotid? Is that it's probably not that. So it requires a lot of expertise. We had limited training data, but the impact that we were going for is to create visualization for patients to understand their cardiovascular health, right? So if the idea is I could show you, hey, this is what a healthy artery looks like. Here's yours, and it's got a bunch of stuff going on in there that you need to pay attention to. The goal was to get better treatment compliance. So this was a sort of a straight up machine vision project that we did. Um, sorry. And then the next one was another machine vision project, but for very, very different reasons. And so in this case, we were doing visual anonymization. And so what does that mean? We had a company that was pretty large that wanted to build a training set. So in particular, what they wanted to do was to classify skin conditions. So they had people that were taking pictures of various skin conditions, just using your cell phone in your home. And given those images, they wanted to ask doctors to label them. Right? Like, what kind of a skin condition is that this person has? The problem is that you needed to mask all the personally identifiable information to protect patient anonymity. So you needed to mask facial features, clothing, the background environment, tattoos, right? So what you really wanted to do was take an image and mask out the things that could be used to identify that person so that you could then transmit that safely to somebody who is going to annotate it. So um, what we did was build a variety of models. One was to do face detection. So we had a model that we got actually off the shelf that uses sort of 454 landmarks from a face image to identify the eyes, the eyebrows, and the lips. And the idea was that the company said, hey, let's sort of mask those things out on the image at least, so that we can remove that bit of identifiable information. It's also the case, and here's examples of that. It's also the case that we didn't have any data, so we had to make extensive use of publicly available data. And so here are some of the results that we got from that simply, and they look a little ghostly, right? But the idea is we're trying to mask out information that might allow a person to recognize who that individual is. So that's the face landmark prediction component. Then actually we had to remove tattoos. I mean, it's interesting. So actually many years ago, I did a project in another capacity with NIH, with the National Institutes of Health, where they were looking at responding to disaster scenarios. And they actually wanted to identify tattoos because tattoos can be unique. And if someone is missing in a disaster setting, you might be able to say, well, here's a tattoo that could identify that individual. This was the opposite of it. So again, not a lot of data. So we found a publicly available data set. This is a theme that we see happen a lot in applications of machine vision, where, and we'll talk about that in just a second, and sometimes it's hard to get data before you have the system deployed, but you need to deploy a system to get data. So what do you do? So in this case, we had about 900 images that had annotations, like, and here are some of them, right? So here is an image of a part of a person. That part's labeled as a tattoo. Then can we identify tattoos in new images? Here again are images that we found on the web, and you can see that we're putting bounding boxes on tattoos and those numbers, and there are sort of levels of certainty. So the idea then is that if somebody takes a picture of themselves, they've got a skin condition. So I've got my arm out, and I'm going to take a picture of my arm, but I have a tattoo sitting somewhere on it. I want to mask out that part of the tattoo. And then the last thing was, so now that we can say, okay, we found facial features we want to mask, we found tattoos that we want to mask. Now the last thing is to try and identify just the skin, right? And so we'd like to be able to kind of make the rest of the background disappear. And so we had to de-identify clothes, other things in the background. Maybe you can recognize, I don't know, where I am or who I am based on what you see behind me. Again, publicly available data set, and we just learned a segmentation model. So the idea was, given an image like this, we should be able to simply find a mask on where the skin is in the image and simply return that. So trained up that model, again, got good results there. So the entire pipeline is taking an image, identify where the facial features are we want to mask, find any tattoos, which are on the skin, find a skin mask, and then simply show in the image that you're showing to the doctor the skin region, facial features masked, and the tattoos masked, right? So the challenge here, as I alluded to earlier, was this rather significant data chicken and egg problem. So you couldn't start the annotations until the images were anonymized, but we needed to train data. We needed to obtain data to train the models for anonymization. So what we wound up doing, which is often the case, is you try and use open source data sets. And this is sort of a golden age of data. There tends to be a ton of data sets out there. So there's even a Google data set search engine that you can go and find data sets for. Great website Kaggle that has lots of publicly available data sets for many kind of real world settings. So the difficulty there is that it's hard to know if the images that you're getting in this open source data set are going to look like the ones, if they're going to be representative of the data that you'll see in the real world. Turns out in this case it was a good match because people were taking pictures of themselves with cell phones to show their skin conditions, and lots of the images that we were getting online were just people taking pictures of themselves with cell phones. The other challenge here is that the expert annotators, the doctors, are expensive, right? So doctors' time is precious. They tend to be very busy to the extent that they, to make it attractive to them, they have to be paid to do this thing, and that time is expensive. And so, again, we had these challenges around to get the system stood up. We had to be creative about the way that we source data and built models to try and make sure that they would be useful to start this flywheel turning where they're actually getting real images from real users. They're anonymized. They're getting the annotations back. So that was the second use case. Or maybe it was third. So anyway, I'm going to do two versions of this: machine learning to reduce the costs of tests. Two kind of different kinds of tests. So a while ago, we actually started having conversations with a company that was interested in producing what they called an exercise prescription. So they had done some science where they were measuring your VO2 max. And based on your VO2 max, which is a measure of your cardiovascular health, what they would do is they would prescribe a certain amount of exercise that you should get, that they would call a dose. And that dose was optimized to improve your cardiovascular health. So it turns out, again, they had very nice data that established that. And they had done trials that showed that people's cardiovascular health did improve, in fact. And the kind of exercise they needed to do was not outrageous. It would be walking a certain amount of time every day. But the idea was you should do an amount of exercise that's appropriate, that is going to give you a benefit with respect to your cardiovascular health, but is not going to go overboard, right? So everybody struggles to try and find the amount of time to get exercise in. So the way they did it, though, was interesting. They had a metabolic cart. And this is, again, a term I learned by interacting with people in the healthcare profession. It's a piece of equipment that looks like that. which is you've got a treadmill and you're hooked up to all kinds of sensors and you're breathing, they're looking at your breath, and they get very, very accurate information about your VO2 max. The problem is that that doesn't scale because these metabolic carts are very expensive. You've got to have a place where you can have the equipment, and people have to come to you. So they had the idea, which I thought was quite clever, of saying, well, what if, I mean, really what the metabolic cart is doing is it is saying, we're going to kind of ramp your heart rate up over time. We're going to do some physiological measurements. And then we've got a formula that goes, here's what your VO2 max is. So they said, well, what if we did something cheaper? So maybe if I have a stepper block, right? So I'm going to get somebody to step up and down, right, at a certain pace for some amount of time. And suppose they had a smartwatch that was going to gather heart rate data and a variety of other kinds of things that smartwatches can do. Can we use that to prescribe the dose of exercise? So the problem then was, how do we bridge that gap? Because they had been using these very accurate VO2 max estimates. And now what they've got is less precise information coming from the watch and this sort of, kind of in the wild, less controlled use of a stepper block in a smartwatch. So what we did was we looked at trying to learn a mapping from cheap data to expensive data. So the idea was give and pair data. So if I've got stepper data and I've got metabolic cart data, can I learn to predict the true VO2 max value gathered from the cart based on the stepper data and demographics, right? So the problem is I needed to get the VO2 max, but I needed to figure out how to sort of bridge that gap. And so if we can do that, then we can use the existing dose mechanism. So the outcome there was that we use sort of, relatively old machine learning methods for what's called regression, which is just I'm going to give you some inputs and you're going to predict a real value. In this case, it's VO2 max. And we wanted to do that using the cart data as the ground truth, and the low fidelity data, the stepper data, and the smartwatch data as the input. So we actually, as part of a company, built an app to manage the data collection. And the idea was that based on simply using machine learning methods to kind of bridge this data gap, they had a scalable solution which could significantly increase the impact of this by allowing more people to participate, to understand their cardiovascular health, to get this exercise dose and to benefit from it. And so people who used this prescription mechanism often showed, as I said, improvements in cardiovascular health and like felt very good about the fact that they were able to do that. So that's this sort of one idea of learning to kind of minimize the cost or reduce the costs of tests. And then I think the last example is, again, sort of in the functional medicine space, we worked with a company where the doctors who were looking at you very holistically may recommend a wide variety of blood tests. So some of them are expensive and they all take time. And so the question that the company had was, is it possible to predict which tests are most likely to come back abnormal, right? So if I could look at you as a person, look at the data that I've got on you, and make predictions about the probability of a test coming back indicating that you had a need to get followed up on more, then I could reduce time and expense. And so what we did was we worked with them to train what's called a classifier. So it simply took biomarker and genetic data and some other demographic data. And we had a bunch of patients where we had that information, we had blood tests, and then we could simply learn to go, okay, if I look at you as a person, do I believe that that test is going to come back abnormal or normal? And it was slightly more complicated than that. It wasn't always just abnormal or normal. There were a few different levels in there. But importantly, we wanted to get a probabilistic prediction. So, there's a difference between, yeah, there's a 98% chance that test is going to come back showing a problem versus there's a 52% chance it's going to come back showing a problem, or a 20% chance. And so the idea there was that you could then use those results to recommend tests. Again, if I've got sort of a limited budget of anything, in the previous functional medicine case, it was I have a limited budget of attention. In this case, patients are going to have sort of limited tolerance for doing blood tests and taking the time to do it. Can we focus our attention as healthcare providers on the cases that are going to be most important? Okay, so now I'm going to come and talk just a little bit about large language models. I've got just 2 slides here, but hopefully the discussion will go, or I'd be very happy to get questions here or at any point. So here's what I did. I'm going to show you a prompt. So large language models, when I'm talking about large language models, I'm talking about things like ChatGPT, or any of the variety of ones that are out there, Google Gemini. So I'll mention Gemini in just a second. So here's what I did. I cheated a little bit on this presentation. I will say everything prior to this point was produced by humans. I have 1 slide where I'm asking ChatGPT to help me out. So what I'd like to do is just show an example here. So what I did was I went to ChatGPT and typed in the following prompt. And this prompt actually contains a couple of errors, which is also kind of nice. I said, I'm giving a presentation on applications of AI in healthcare. The article linked below entitled, it was supposed to be, I said, entitles The Future Landscape of Large Language Models in Medicine is a well-cited, I should have said, is well-cited and appeared in the journal Nature. Can you extract bullets for 1 slide on how LLMs can be used in healthcare? And I just gave the link, right? So this is just off-the-shelf Chat GPT. And what it does is it goes out and grabs the article and responds to that particular question. And then, I think there are links here, right? It goes, okay, right, there's, where you can get it. And it turns out it did a reasonably good job of summarizing the article. I think some of these applications that the article calls out are a little bit sketchy, and we'll talk about that in just a second. But they're talking about improving patient communication. So LLMs, large language models like ChatGPT, excel at tasks where there is text. And what I would like you to do is to do something with that text that you might ask a capable assistant to do with it. So, for example, you could say, I've got this patient, I've made these recommendations, they have questions about their conditions, let me gather some articles about that. What I would like to do is to have you summarize that thing. And that's actually exactly what I did here. I just said, boom, here's a URL, please give me some bullet points on that. So those kinds of applications are perfect for large language models. Now, the next slide will actually have some caveats on that. Assisting in clinical decision making, right? So it is the case that, I think medical professionals can use large language models to do a couple of things. One use of a large language model is just to say, hey, tell me what you know about this medical condition, or here is how a patient is presenting. What do you think? Now that a little scary if doctors are out there doing that, because you're trusting that the LLM sort of knows, has that baked into what it knows by its training. Other ways of doing that are by augmenting it with text. So I've got a library of text documents about particular kinds of conditions. There's a method known as RAG, or retrieval augmented generation, where you can say, what I would like you to do is go look at this text over here, find information in those documents that are relevant to the question I'm asking, and give me answers based on just those documents. So that's what I did. I said, hey, I have a question about this document. Base your answer on that document. Now, this answer is great, right? It's definitely coming from the document. But the thing that I'm getting with the language model is that ability, that like amazing facility to operate with text, with natural language. So again, you have to exercise care. Medical documentation, enhancing medical documentation, supporting medical research. Again, so I don't know if I said earlier today, but I'm also a professor of computer science. I do research. I actually find ChatGPT to be remarkably useful just for sort of like bouncing ideas around. I don't take anything that it says as ground truth, but it helps me sort of identify areas that I might want to think about as I'm working on problems. And then again, sort of advancing, medical education. What I would say is that the applications that we see a lot with large language models tend to be just doing things with documents where like sort of precision and accuracy may be important, but there's a human sort of writing on top of it. So document summarization is great. So if I didn't want to read that article, I could say, hey, summarize it. It will do a good job of that. I could ask questions about the article. I could say, well, tell me more about how it can be used for improving patient communication, and the language model will do that. The other thing that they're good at doing beyond just summarizing and question answering is producing text. So you could, for example, generate doctor's notes. And I'm working with a student who's doing that right now, where you can take images, actually, of skin lesions, oddly enough, given our earlier example, and then some information from the doctor. And can you write a note describing what the doctor would have done? So they can do it with different tones. So I can be formal and professional, I can be more familiar, and with kind of different levels of what I'm calling expertise. That is, you can actually say, write this as if you were speaking to another medical professional, or write this as if you were speaking to a patient who doesn't have deep medical knowledge, but kind of wants to understand their problem, or their medical issue. The other thing is that it doesn't have to be text. There are also great integrations with things like spreadsheets. So I don't know if any of you out there use Google Sheets, and they have an integration with Gemini, which is Google's large language model. But if you are in a Google Sheet, you can say, hey, summarize this data, tell me about this data, combine it in the following way. And then it's just this like partner that's sitting over there with you, helping you analyze and understand what's going on in a spreadsheet. And so you can blend those two things. You can say, here's some additional text. I'd like to sort of bring this data in and do some summarization, or engage in these other activities. So the opportunities here are sort of limitless, and it's almost the case that you have to impose some constraints to say, here are the problems that I'm having to even think about where to get started. There are some challenges. LLMs are not medical experts. Obviously, that goes without saying. However, it's easy when you're talking to a large language model in an area where you have some level of expertise to be kind of amazed at what it knows. So, like I said, I'll ask ChatGPT questions about machine learning and research that's going on, and very often I find its output to be useful at the level of kind of orienting myself and thinking about problems in interesting ways, almost never about solving them. And it often will give me garbage. Like, it'll give me pointers to papers that don't exist. I mean, that's kind of classic behavior. In domains like healthcare, like patient-facing healthcare, for example, human oversight is going to be critical. So I did a webinar much like this about a month ago on AI in the legal profession. Exactly the same argument, right? When the stakes are high, you need to have a human looking at what the LLM is doing. Um, the other thing is that, like, one-off use is very different from integration into a workflow. So if you're a healthcare professional and you just want to use ChatGPT to do stuff like I did for, that one slide in this presentation, easy to do, trivial. However, getting these systems integrated and embedded in workflows that you might have ongoing can be quite another effort, right? So one-off use is a thing that a person can do. It's easy, pretty painless. But if you want to actually sort of have it deployed at a larger scale, it typically requires somebody that has the appropriate expertise. There's also issues of, bias and fairness. So LLMs are trained on lots of data, publicly available data from the internet, other resources. That data is being generated by people. People have biases. People can be fair or unfair in the way they deal with different groups. Those biases are often manifest in machine learning systems in surprising ways. And so, you have to be careful that the LLM is not giving you responses that are biased in ways that are not in the best interests of whatever the use case is. Obviously, in healthcare, there are data privacy and security issues. So we often have people say, nope, right? Like, you are not using a cloud-based, you're not using ChatGPT. We got to do local hosting. Now, the good news is in this case that there are great models out there that are not massive, that can be hosted locally. There are also secure cloud platforms for doing that. So all the cloud providers make it possible to do things in secure ways that are protecting privacy regulations. But the challenges are different, right? So if you're doing local hosting, you got a box, it's sitting there in your office. You got to pay money to sort of get a large enough GPU to run that large language model at the appropriate speed for you. That's one set of concerns. Getting it hosted in the cloud is a different set of concerns because then you have to go through a lot of hoops to make sure that you're sure that your data is being protected. Sometimes there's lack of explainability. So large language models are great about sounding very authoritative on things, but you don't know where that's coming from. That bothers some people. I think it's interesting, and I'd be happy to answer questions about it. But we're getting a better handle as a research community on what LLMs are doing and how they represent the world. But that's very different from getting some output from a large language model in a healthcare context and saying, like, well, why are you saying that? You can go down that rabbit hole and interact with the LLM, but you may never get to the bottom of it. And then obviously there are legal issues. So do you need to get patient consent if any of this is patient facing? What happens if there's a malpractice lawsuit, right? So how does the fact that a language model is involved make that better, worse, more confusing? So there is enormous potential for the use of large language models in this context. But you have to think kind of carefully about what the challenges are. So, um, as I said, I lied on my outline slide about having final thoughts. What I would say is that I'm hoping what you take away from this is that the kinds of applications for artificial intelligence in healthcare are incredibly varied. So we looked at cases where we're learning predictive models, where we're just kind of counting and looking at statistical associations, where we are using machine vision models to extract useful data, and then where we're using modern large language models to sort of wade through volumes of text to do a variety of things. So um, lots of potential. You need to be careful about how you do the deployment to make sure that you're doing it in a way that isn't going to lead to kind of downstream harms, and like always keep a human in the loop. So thank you very much for listening. I'd be happy to answer questions if there are any at this time.
Thanks so much, Tim. That was a great presentation and one we can all relate to regarding, as we've all been patients in healthcare. Found it really enlightening. If there's any questions, we haven't gotten any so far, feel free to pop them into the chat or into the Q&A. As a reminder, we will be sending out this presentation via email, so be on the lookout for that shortly. And if we don't have any questions or comments, then I will go ahead and sign off for the day. Thanks again, Tim, and everyone have a good rest of your afternoon.